Good afternoon, everybody. It's my great pleasure to welcome all of you on our webinar. That webinar is dedicated to Road to Kyoto. That's a very interesting topic, you know, that's organizing between European Association of Nuclear Medicine as well World Federation of Nuclear Medicine and Biology. And this webinar is aiming to provide you some background about the Theranostics, which is the main topic for this World Federation Congress this year in Kyoto. And this is for us a great pleasure that we have today 4 distinguished guests from over the world, because we have represented from US, from Asia, Europe, as well South Africa. Let's start. Paola, I give you now the voice.
Thank you, Yola. And let me welcome everybody. This is not a typical ESMIT webinar, but we are using more or less the same organization. I would like immediately to start by introducing the first speaker, Dr. Anna Sovastoka. Hope I was right. Anyhow, you can correct me, Anna. She is working in the nuclear medicine unit of the endocrinology department of the Jagiellonian University in Krakow. And she will give her view on the current situation of Theranostics in Europe. Anna, please, the floor is yours.
Good morning, good afternoon. One moment, please. Do you see my slides?
Yes, Anna, perfectly.
Okay. Okay. Thank you for your invitation. The idea of Theranostics, which is the future of personalized precision medicine, sometimes called tailor-made medicine, is a very important issue, especially in the context of a growing number of cancer cases. At the moment, we are talking here in Europe of two types of cancer, namely NETs and prostate cancer. Of course, the basis of Theranostics is imaging. Let's start with neuroendocrine neoplasms. In clinical practice, scintigraphic tests with indium octreotide are still performed, but we also have a technetium Heinig talk. The first registration is in Poland, took place in 2004. Currently, the recipient of dextrotide is many countries in Europe. As we can see, many countries perform scintigraphic tests. However, as we know, the gold standard in the diagnostic of NETs is PET examination with gallium-68 labeled somatostatin analogs. And Eckert-Ziegert generator is available in Europe. In Poland, it was registered as a medicinal product in 2015. Another generator, Galli-ET, produced by IRE Elite, is registered in 13 European countries. A kit for labeling somatostatin analogs. In Europe, it is Somakit.talk. Personalized medicine with the use of Theranostics is, of course, the possibility of conducting treatment based on the results of an imaging test using the same radiopharmaceuticals. Based on the results of NETHER-1 study, which compared the use of lutetium dotatate with octreotide LART at the dose of 60 milligram, Lutathera was registered for the treatment of inoperable or metastatic progressive, well-differentiated gastroenteropancreatic neuroendocrine tumors expressing somatostatin receptor in adults. This, we can see the list of countries with refunds. We are still waiting for it in Poland. Before the registration of oxodeoxyribonucleic polatome registered Lutapol and Itrapol for the labeling of precursor, including somatostatin analogs. Lutapol is used by such countries as Greece, Austria, Serbia, Poland, and Itrapol in Serbia, Austria, and Poland. PSMA, an antigen found on the cell membrane of the prostate cells. We currently know that PSMA can be combined with gallium-68 or fluorine-18 in diagnostic, making it possible to assess even large lymph nodes in search of metastatic foci. Moreover, the PSMA antigen has become a therapeutic target in the treatment of patients with disseminated cancer metastases that are no longer responsive to hormone or chemotherapy. For this purpose, the radiopharmaceutical is labeled with beta emitters lutetium or with alpha emitters actin. We are waiting for registration of a kit for the preparation PSMA with gallium or lutetium PSMA from 888. ABX PSMA 2007 is authorized in France from 2021. Other kit PSMA 11 to labeled Gal-68 produced by Polaton is available for commercial purpose and is sold as a marking kit in Poland and is outside Europe to countries such as Israel and Saudi Arabia. In Poland, we use this with the consent of a bioethics commission. What is the future of Theranostics? We hope that various international programs with vary or are underway, for example, Transcan, which included research with a new analog of gastrin in patients with progressive of metastatic medullary thyroid cancer, as well as others with the use of new ligands, will further open up new possibilities for personalized medicine. Thank you for your attention.
Thank you very much for this wonderful talk. As our president, EANM president, Professor Kulikowska already said, this is the road to Kyoto, which means we're going to have a total of 4 different talks. And after Europe, we're now going to jump over to China. We're going to hear about the current diagnostic state of our field in China. And I'm very glad to announce next speaker, Dr. Chen from the Xiamen University in China, one of the front runners in Theranostics in China. And we're very excited to hear about the current state of Theranostics in your country. Very welcome.
Thank you. Thank you for the introduction, Dr. Herman. So just to know, Anna gave a very detailed introduction of the Theranostics, but as for China, I think the Theranostics in China is still in a very preliminary stage. So I may not be that detailed in my presentation. I will only introduce how many theranostic centers in China and what kind of therapies we are currently performing and how I will see the future of theranostics. So firstly, let me share my screen. So, okay, so can you see the screen?
Yes. Yes.
Okay, thank you. So I will give a very simple presentation regarding the theranostics in China. So hello everyone, my name is Haojun Chen from Department of Nuclear Medicine at the First Affiliated Hospital of Xiamen University. So first of all, let me give a brief overview of nuclear medicine in China, because the nuclear medicine in China was born in 1956. So it's still a very young subject. And the Chinese Society of Nuclear Medicine was founded in 1980. And these 2 key persons, they are this is Dr. Sijing Li, and he's the president of EANM, and this is this lady. She's Wang Jing, and she's the resident designate. And I got the most of the data in my presentation from the results of the National Survey of Nuclear Medicine in 2020. So currently, there are over 1,000 nuclear medicine departments in China with over 12,000 staffs, including the physicians, nurse, and the technicians. So this is the PET imaging situation in China. So last year, we have nearly 1,000 SPECT imaging machines and over 400 PET machines in China. And this map shows the distribution of nuclear medicine equipment in different parts of the China. So we can see most of the nuclear medicine departments distribute in the eastern coast of China. And these two figures shows the types of PET scans in China. So we see the upper row is the PET CT scan, and most of the PET CT was used in the oncology, including the cancer diagnosis, cancer staging and restaging. And the lower row, this is the PET-MR scans. The types of PET-MR also, like the PET CT, mostly used in oncology, followed by neurology and cardiology. Regarding the radionuclide therapy in China, we currently have over 700 hospitals in China last year, and we have over 2,000 hospital beds for the radionuclide therapy. So this figure shows the types of radionuclide therapy in China, and we can see that most of the therapy was performed in the iodine-131 for the hyperthyroidism, and followed by the strontium-90 beta ray applicators, followed by the thyroid cancer treatment using the iodine-131. However, for the lutetium therapy, it's still like in the very preliminary stage. There are some problems in China regarding this kind of therapy. So first of all, the therapy radionuclide, including the lutetium or yttrium-90, they are important dependents, and no therapy-related radiopharmaceutical is currently approved by the NMPA. And we have like very strict regulations for the medical isotope, and there's shortage of medical personnel in nuclear medicine departments because there are only 1,000 nuclear medicine departments in China, but and over half of the tertiary hospitals and 99% of the secondary hospitals have no nuclear medicine department. So these are the problems, and this is I summarized the theranostic study in China because we do not have like a specific theranostic center or cancer center in China. So the theranostic studies can only be performed at the Department of Nuclear Medicine in general hospitals. So based on current publications, I found there are five centers in China conducting the theranostic study, including the Peking Union Hospital. They did gallium-68 lutetium PSMA and the delta Tate for prostate cancer and neuroendocrine tumors. They also did some therapy using the new drug, like the Evans Blue conjugated PSMA or delta Tate. The Evans Blue is an albumin binder, which aimed at prolonging the blood circulation and increase the tumor uptake. So they did this kind of therapy in the hospital. So except for Peking Union Hospital, like the Beijing Cancer Hospital, they did the PSMA and delta Tate. And the Nanjing First Hospital, this probably the largest. This hospital has the most large scale of theranostic in China. They have the most patients of the prostate cancer and neuroendocrine tumors, and they perform these two types of therapy. And except these three, in the west area, we have Xijin Hospital. They did the lutetium and gallium-68 PSMA for the prostate cancer, and Dr. Chen, and he did the PSMA and delta Tate also for the prostate and neuroendocrine tumors. So these are only 5 hospitals currently conducting these theranostic studies. Last year in 2021, the Ministry of Science and Technology and other 7 departments formally released the Medical Isotope Long-Term Development Plan, which aimed at promoting the construction of nuclear medicine in China. So based on the previous dark neck problems I have mentioned, this plan, they have some specific strategies which specifically aimed at solving these problems, including speeding up the domestic preparation of medical isotope, including the lutetium-177. Also, currently we are preparing the other treatments isotope, including the alpha therapy, like the actinium-225. And also, we are currently doing the research and development of new radioactive drugs. And also from the government, the policy relaxation of medical isotope, and we are going to fill up the gap in nuclear medicine departments, equipment, and personnel. So here, because the Theranostics study is still is still at a very preliminary stage in China, we mostly only have like the PSMA and the delta Tate. This kind of drug is currently is not routinely used in the clinic. They can only be used for research purpose. So like this drug, this is the this figure I summarized from the recent survey. And we see some drugs like the lutetium dotatate, it's been approved by the CDA, and other drugs, including the PSMA or the lutetium PSMA, they are still in the application progress. But I believe that with the implementation of the long-term development plan, we still have confidence about Chinese nuclear medicine, and it will welcome a blowout of the development for the Theranostics, because currently the physicians in China and the scientists, that they are very interested in the Theranostic study, not only for the PSMA or delta Tate. We are still interested in many other targets like the FAP, which highly expressed in virus types of cancer, and the 6CR4, which is the target for the like multiple myeloma or advanced lymph node or some high-grade neuroendocrine tumors. Okay, so that's all for my presentation. Thank you. It's a very simple one. Let me end the share screen.
Thank you, Dr. Chen, for your overview about the China. As you see, we follow by the Europe to China, and now we are flying to the South Africa, and it is my great pleasure to introduce you Professor Mike Sateger, our good friend and well-known PSMA with the actinium guy. Mike, the floor is yours.
Thanks for that introduction, Holland. Really appreciate that one could hear. I see a lot of friends and colleagues and mentors that are here in the meeting. Hope you can see my screen. Sorry about that. Just a brief reminder that in South Africa, we are following this principle when we are really doing our Theranostics as a way to Kyoto, that we have both the imaging side and the therapy side that we are developing, looking at really trying to understand the biology of the tumor well, and also trying to understand the characteristics of what can be important to treat. In South Africa, and therefore Africa, which actually sends us students usually to South Africa to learn, we happen to do Theranostics at various scales, and all of this is what we do have in the continent. We have started, of course, with our lovely thyroid in doing Theranostics, which we do well. In the flag of what is happening now, it, of course, prostate, and we are encouraging technicians, even if we actually have access to both the gallium and fluorine, and then, of course, the neuroendocrine and neuroendocrine tumors and cancers are thriving, and as well as this MIBG, which is a bit established. We do perform liver neoplasm as a Theranostic as well, and the bone palliation for pain is still something that we do, and it's a full scale. Characteristically, we are looking at trying to see if we are going to also get involved in the technetium and rhenium for both things like septin, as well as including some of the other molecules that might be technical, but that's futuristic. This is what we are doing at the moment, and it's established, and it's done in both public and private. The only thing that is not done in public is the actinium, for instance, but the rest of the diagnostic therapies are really done there, and we are happy that this is happening, and we can only encourage it well. But with the advent of now saying this is the flag of what we are doing, we are at a stage where we are revising our protocols in terms of how we train our students. Just to give a brief bit of an overview, in South Africa, we do have 19 cities, and then 8 of which are in the university hospitals, and then 11 in the public sector. We've got 86 gamma cameras in the entire country, around 65 nuclear physicians, and a lot of the people are really, of course, radiographers. In our training, it is 4 years to be a specialist in nuclear medicine. That is immediately after being an MD. And then we are starting to emphasize radiobiology and, of course, issues of physics, as well as making sure that we can understand palliative therapy, so that when our patients are with us, we have to realize that we must treat the entire spectrum and make sure that this is something that we understand, given the fact that some of the oncologists might also be having interest in this. And then for this to happen, as for Theranostic, we must create a sense of knowing that we can be able to train and expand from where we are, and not just be content with what we have. As we speak, I'm sure you can perhaps hear the noise behind me. I'm seated in this office here in the hospital here, where my arrow is, but behind me, this building, which is this, it is being built. It will be having a preclinical facility, the basic and translational research, and then it will obviously do the human research in therapy, infection, and then it will have 2 cyclotrons, which will be behind me. At the moment, we are having 2 scanners and 4 gamma cameras, for instance, in my butt, but this will be a nuclear medicine research infrastructure, so that we can actually train for the country and also for some of the continent. This we had to happen in also to influence the curricula because of what Theranostic has done and is doing. And this is a great opportunity to emphasize that Theranostic is really great, but we as nuclear medicine people, we also have to take leadership of this. And this is an example of such, of showing that in the country, we also are keen and always try to collaborate in multi-center studies, because we cannot, as a continent, be seen to be doing single studies only. So to this meeting and for you inviting us, it's important to show that we actually have to be involved with the issues of multi-center studies. But I just want to say that one is also thankful to our recent publication that had shown that in a post ADT, which is a thing that we have commonly here in Africa and South Africa, that most of our patients, at least they may present late and they may have ADT, and after that they have nothing. So for that situation, we have to try and have a way of using Theranostics to try and make it relevant to our people. And this work demonstrates that it does work, it can work, and it does achieve excellent results, wherein you can see overall survival, which is not reached after 55 months, and 91% success. Really, that shows it's good. Of course, we have to really handle it well, hence the curricular change, and also make sure that this is something that will be sustainable. And one is saying that this type of a situation of Theranostic is important, and to the people in the meeting and organizers and invite us. One is thankful for this opportunity to actually show that indeed this is something that we can actually, and speak to oncologists to say it's not a one-size-fits-all, and it is not only the certain therapies that are known, but at this stage we should try and work together to see if we cannot extend this period, which is currently a bit shorter and expensive, utilizing our diagnostics. And this will work well, of course, for my continent, because radiation oncology units are not often there sometimes, but some of the departments and countries are having already gamma cameras, which we can use technetium PSMA as an example to actually then follow up with either lutetium or actinium, probably lutetium at the moment. Again, this is just to demonstrate again that the power can be there for both, where radiation oncology cannot work in the brain, lung, and extensive diseases. So why one is showcasing the prostate, because it's actually the place where, yes, thyroid is the thing that founded this, but the impact, if we're going to make it big and really to get nuclear medicine in a developing or rather in low middle income countries to work, we have to show it with diseases such as the prostate and hopefully breast in the near future, to show that the impact is great and it's happening, and we have a good take up into this, and we hope that the continent can come through. And my last slide is to say that really Theranostics is really being embraced. Our policymakers in the continent through and via the IAEA is really coming up well. And we are demonstrating the improvement. We are demonstrating that we can work on the side effects, but importantly, we must be trained as nuclear oncologists and have a multidisciplinary approach. Realize that it's important for the and thanks for the invite again, that the countries such as Africa has to be in the trial so that we can have a real world experience in what we are doing. And of course, hopefully, as we speak, we can make it accessible, available and appropriate. Thank you.
Mike, thank you very much for this excellent talk and a lot of compliments to the outstanding work you're doing. And I also have to tell you a lot of compliments to your architects. This building looks much better than my new building. So compliments there. After having heard very exciting news from China, from Europe and Africa, we also want to, of course, hear what's going on in the US. And it's my great honor and pleasure actually to introduce you to my mentor and role model in nuclear medicine, Professor Johannes Chernin, who is the chief of the Division of Nuclear Medicine at UCLA, the editor-in-chief of the Journal of Nuclear Medicine, and will now give us his view of theranostics in the US. Johannes, please take the stage.
Can you see my slides? Because I don't.
Not in presentation mode yet. Now, perfect.
Okay. So thank you very much. I start with this one because I cannot keep up with the beauty of Mike's center and even the one in Essen. This is what we are building right now. This is a Theranostic center that will enable us. It's an outpatient center. All these treatments are outpatient treatments in the US. Will enable us to treat 16 patients per day or give 16 cycles per day. It has ocean view, which you don't see very well on this part here. Here, my conflict of interest. So I thought I'd do what they call a SWOT analysis, which is looking at the strengths, weaknesses, opportunities, and threats of theranostics. And I start out with the future of theranostics. I start out with the strength. And I think one of the key features that have emerged over the last years is that we have robust diagnostic data. And they come from both the collaboration between UCLA and UCSF, and Ken was integral part of getting this going at UCLA, but also from Lantheus, so that we got, misspelled, PSMA11, PYL, and the Telix kit based on the data, that diagnostic data for initial staging and for biochemical recurrence. We got this FDA approved, and so this is now available for patient care. It's also part of the NCCN guidelines, and there's also Medicare, which is the public insurance here, and private insurance reimbursed, which is a very, very important aspect in the United States. We do have definitive therapy data, and I only listed prospective studies here. Resist PC, that was a UCLA trial. LuPSMA, that comes from Peter Mack. The Vision trial, of course, which was the final definitive phase preclinical trial. And the therapy trial, which moves the treatment earlier, as it suggested in a phase 2 trial, a benefit of lutetium PSMA over a taxane, standard taxane regimen. We expect lutetium PSMA 617 to be FDA approved within the next few weeks, actually. So this is all good. The other thing that I will show in the end, there's a real strong clinical need, not only for imaging, but also for the therapy. And I'll show you some numbers a little bit later. The weakness is that we all get very happy. We get very self-happy because we think we have something that is really great, and it is really great. But therapy responses are suboptimal. We have, on average, maybe less than 50% even PSA responders, and the survival benefit coming out of the Vision trial data is not spectacular. That, of course, is something to do with patient selection, and there's progress being made, mostly spearheaded by Peter Mack's approach of using not only PSMA imaging, but also FDG imaging for better patient stratifications. There is a lack of research to dissect resistance mechanisms. That's something that we have tried to do for a long time. There's not enough time to talk about this, but this is something where we need to create a much deeper research effort to understand why 50% of the patients will not respond. Another weakness is complacency. I think Mike Phelps used to say, where there is comfort, there is no progress. We need to be really aggressive about understanding much more deeply and much more solidly the biology of disease and the biology of resistance. And I just list here a few of the resistance mechanisms or improvement opportunities. It's the radiation type, Mike talked about this. It's the injected activity, which I think we underdose patients notoriously. It's the assessment of target expression, and it's also tumor perfusion, because in the end, this is also a drug that needs to be delivered to the target. And again, in biology, it's a mutational status. We know that p53 mutations are probably inducing radioresistance. It's DNA damage response and repair, and it's the immune landscape. And here list the opportunities. Again, improved understanding of resistance. So crisis is also opportunity. We need to arrive at combination treatments. It's very obvious in oncology, there's very few cancers where you have a single agent treatment. Earlier treatment, Mike showed that with his actinium study, but this is too small for you to really read, but I just want to give this as a teaser, but there are large numbers of studies ongoing that move the radioligand therapy to much earlier stages of the disease, even into the realm of neoadjuvant or adjuvant treatments. And then, of course, other opportunities are novel theranostic pairs, and we mentioned, a colleague from China mentioned already FAPI and CXCR4, and there are, of course, others emerging that will give the field many years of success in the future. But we also have real threats. The one is supply chain challenges, and the geopolitical insecurity currently underscores that this is a very tricky issue. We have a lack of centers in the United States. I will talk about this in the next slide. And we clearly have a lack of competence and training. I just want to emphasize here that, for instance, the current actinium supply at best needs about 3% of the actinium demand. So I think that the industry is challenged to really find solutions for this problem, so together with academia. So how many centers are needed in the United States? So I took these numbers from some incidence numbers, not prevalence numbers, and came up with very conservative estimates that we probably would need to begin with 7,500, we'll have 7,500 patients with neuroendocrine tumors who would benefit from Lutathera. And if you assume 4 cycles in each patient, that would give you 30,000 cycles. And then for lutetium PSMA, I would estimate that you would need 40,000 patients per year. And that is the number of very late stage patients only. I think the mortality every year is like 35,000 or so. So again, it's a conservative number, but that if you have an average of 3 cycles per patient would give you 120,000 cycles per year. So that for the United States, you would need 150,000 cycles. So to get to these 150,000 cycles, if you have 70 centers, they need to give around 2,100 cycles per year if the cycle can give 8 cycles per day. Now that's a large number of cycles. If each cycle can only give 4 cycles a day, you need obviously 140 cycles. And if they give 2 cycles a day, you need 280 centers. So for USA, there's a lot of work to do because we are far away from the number of centers that can provide the service. I think that Europe is way ahead of this, and from the data that we saw from China, I think there's a lot of work to do there too. So another threat is insufficient training for operating a center and for having the competence. This is my last slide, but there are 2 papers coming out, one from the Australia-New Zealand group. This is in press in the Journal of Nuclear Medicine, And the joint publication coming in the European and in the Journal of Nuclear Medicine, that's kind of an enabling guide how to set up a theranostic center. But what is needed is really competent in biology, physiology, radiation physics, in theranostics. We need to improve patient selection. We need to understand the standard of care. We need to place theranostics among the appropriate treatment options. So we need to become consultants that are respected and know the field of urology, oncology, endocrinology, wherever we are working. Understand indications, contraindications, and managing the adverse events and side effects. Of course, radiation protection for patients, staff, and the public. We also need competent nursing and technologies training. So this is my last slide, and with this, I thank you very much for your attention. I hope that this outlook was not too pessimistic. I think realism is obviously, but to me, a very important aspect of planning the future. Thank you very much.
Thank you very much, Johannes. Now we had 4 fantastic talks, and together with my wonderful co-moderator, Paola, we're going to have a hopefully very interactive discussion with the whole panel in the next 20-25 minutes. So I please also ask all the other members to turn on the cameras again. And for all people in the audience, please use the question and answer tool and provide us with many, many questions. If not, I tell you, I will abuse my position and ask myself, the experts, many questions. So Paola, the first question goes to you, however.
Yes, thank you. Thank you very much. Really very interesting having a live taste of what's going on, and I am thrilled to see how much your talk were full of education, because as you know, we are putting a lot of efforts in trying to complement what the medical schools and the resident training program are at the moment delivering in terms of education, and transform this to a long life learning experience. So I would really ask everybody to send a question and answer. We have one for Professor Chernin, and it's about his experience. It's a very practical one in Illuccix versus FIL, if he can comment a little about that.
So I think the question was Telix versus PYL, and I don't have experience with the Telix kit. I just know it's a valid and valuable tool that is also FDA approved, and people use it a lot. I see no problems with it. PYL is now also available nationwide, and then the latest numbers of Lantheus came out a few days ago. They now predict 60,000 doses to be delivered this year. We have Ken and I actually did a calculation more recently. We believe that within a year or two, we'll get to 160,000 doses in the US per year. It is reimbursed and it's available. At UCLA, we use PSMA 11 because that's where we have our own FDA approval, and that works very well. We do 8 patients a day, and the waiting list is very long. I can't tell you any comparison between PYL and Telix because I have no data, but I wouldn't doubt that all the 3 options that are available in the US are equivalent.
So the next question comes directly from the chat. It goes to the whole panel. Is what about the role of dosimetry? Do you perform dosimetry in all patients? And I think we start off with you, Mike, go via Poland to China and then back to Johannes.
Oh, thanks for that. We do have information on dosimetry on lutetium dotatate and lutetium PSMA. On actinium, unfortunately not. We just be piggybacking on the lutetium work and what has been done in the US and in Germany. So we also have not been doing dosimetry for a while in thyroid as well. MIBG occasionally we do. So yes, indeed, now that we have that routine of doing some of this work, so what we do, we end up just scanning the scans, the post-treatment scans for lutetium dotatate and PSA, but not routinely practicing them unless when we're having a rechallenge. So we accumulate the data in most of the time when we are under pressure. So in other words, dosimetry is applied to those challenging cases, but we accumulate the data for in case we have to rechallenge. So
thank you, Michael. Anna.
Okay. Normally, we don't make dosimetry. During a few days, we start a new program. It is a dual-NAN, but it is a clinical program. And in this program, the dosimetry is necessary. But normally, we don't use in our center PSMA, and we don't perform dosimetry.
Dr. Chen.
Actually, in our hospital, we are not doing the dosimetry because we do not have the quantitative SPECT. The SPECT machine in our hospital is still a very old one. It can only do the scintigraphy scan. But for some hospitals, as I know, like the Peking Union Hospital, they have the most advanced equipment, and there are some like new drugs in new drug clinical trial in that hospital. Every patient in that hospital, I think they are doing the dosimetry, especially for the new investigational drug. It is a must for this kind of study especially for like the lutetium. I think every patient, they will do this kind of dosimetry study. Thank you.
Johannes, last but not least.
Well, we are not doing dosimetry yet, but as you know, it's a focus of SNMI, and it was a supplement for the Journal of Nuclear Medicine that was published on this issue. There are clear indications that it is going to be very important. We know it from preclinical studies. In murine models, we know that the responses are much better when you up the administered activity, but there are also data that show that if you get higher tumor doses, the PSA responses will be better. There's a paper from Australia. I think the key is really not so much the defensive aspect of dosimetry, and that is protecting bone marrow, whatever, and kidney, but it's really the offense that is important, and that is increase as much as possible the delivered dose to the tumors. And so I think that should be the aim here. And it's no question it will be coming. I think there will be dosimetrists like you have in radiation oncology. We will have the same in nuclear medicine. And there's no question that this will be a kind of condition for diagnostic centers to do that.
So Mike, you raised your hand. You want to comment on this quickly, or should we move on to Paula's next question?
I was just briefly saying that one of the other things, that's why I was saying we end up accumulating data. It's still a tedious thing. One of the things we've got to really make it a bit easier so that it can be easily done and routine, because if it's tedious, then it's not usable.
Yeah, so that was my question, because we have somebody following up this question asking why you are not performing. So in a word, what's the reason why you are not performing, Mike? For you, is practicability? It's too complex?
It is really, yes, and it is complex, and you start worrying about reliability about it, because if you do something, it must actually tell the truth and tell you the state of affairs. You don't want to do something as a tick box, so rather accumulate the data, and if needed, can do it as a retrospective analysis and be sure that you're doing a good job. Yeah.
So it's also reproducibility, so it's not only practicability.
Two quick comments here. I think even our president gets involved, and Johannes again.
It's a very short comment with this dosimetry, because you know that always this is our discussion. And you know that this problem is that this is time consuming, was the mention. And you know that our patient is usually not in the well condition. If you need to perform 3-4 time point scan, and it's not good for the quality of life of the patient. And please remember that still with the dosimetry, we are only prediction. It is not a real dosimetry because we didn't take this biology of the tumors there. That still this dosimetry is not perfect. That we need to find this one-time point, like Mike said, that will be very easy to calculate over the doses. And this is, I think, the most important, that we need to think about the safety of the patient, but the quality of life of the patient too. And all this, you know, the dosimetry is doing usually during the clinical trials, that for the registered product, it's quite easy for follow for this kind of the rules. And Johannes, for you?
So my point would be that the quality of life would get better if the treatment is more effective. So everything that we can do to make the treatment more effective would be important, and it will increase quality of life. And it's clearly not there yet, as Mike said. It's, you know, doing it routinely is very difficult right now, but we'll do everything we can to set it up. If you think about chemotherapy, giving everybody the same dose would be absurd. I mean, people would say this is crazy. And when you talk about precision medicine and you say, but we don't need to do this dosimetry, we don't even know how much we deliver to tumors in radiation oncology, of course, you know it very well. So I think we need to just simply come up with solutions that are feasible and realistic and practical, as you said. But then I think we need to do it. I think there's also an important aspect for the field of nuclear medicine, because everybody hates to do dosimetry. So I think that is almost like a protective mechanism for us, because we will do it. Nobody else wants to do it, so we'll keep it.
So I think not to make sure that this is not going to be a pure dosimetry discussion, which I think is one of the most important topics of the future. My personal 2 cents there, it's not going to be black or white, not no patients, not all patients, probably somewhere in the middle. And I fully agree with Johannes, we at least need to include it in the clinical trials to make sure that we do not undertreat patients constantly. If we're able to really do the personalized, probably will depend, right? But definitely one of the fields where we put a lot of intention. It's not a surprise that Johannes made a supplement in the JNM based on dosimetry. However, the audience got a little bit warmed up. We have more questions. I think a very interesting one is here. How reliable is it using technetium PSMA and technetium octreotide for selected patients for religand therapy and PRT, especially in areas and countries with constrained access to both modern and expensive PET tracers and PET technology? I think this is a great question. And I would love to start with Mike, because this is your real life, right? You need to manage with a limited, in a country with limited resources. What is your thought there?
I do think in terms of selecting patients, because we need to demonstrate that there is uptake that is above a certain criterion, be it the liver or background. So there is still a role and a value for there. And remember, what we do, it mustn't be limited to a certain number of people. It must be available to all. And technetium, both dotatate and PSMA do offer that role, and they do play a role. However, sometimes there are challenges with labeling them. We must also make sure that those vials label well and they are solid. But once they are well labeled, they really offer a good job. The only problem is when we have to start to do things like recurrence. For recurrence peaking, which is for small lesions, of course, that might be not the place where you actually might be treating with lutetium anyway. So for that reason, they might fall a little bit short. But for the purposes of selecting the patient triaging, I think that they do very well, and we should support the countries that do not have the PET-CT to actually utilize that modality. It's not about seeing 20 lesions versus 15 lesions. So long as the lesions are there and it's sufficient, I think.
I fully agree with you. Is there anyone who does not agree in the panel with the statement? If not, I'm excited to hear the next question, Paula.
Yes, next question is about the continuation or discontinuation of androgen treatment during lutetium PSMA treatment, so the cycle of therapy itself. So can we have, for example, the opinion from Europe and China on this? What are you currently doing with your patient? Anna, are you keeping the patient in therapy, or are you discontinuing the therapy during the treatment?
I have an experience with therapy with PSMA with lutetium, but probably problem is in Europe is due to having possibility to treat because we haven't registration of PSMA lutetium in this moment.
So maybe an answer there is that just remember how vision was done, right? Vision was done where a standard of care was defined, and then lutetium was added or not. If I remember correctly, and I should remember correctly, ADT was not excluded. So chemotherapy was excluded, radium was excluded, ADT was not excluded, which means, being politically correct, we don't know how the label will look like, and FDA will be the first one to approve, but I think it will be at least allowed to combine with ADT. If you should stop or not depends obviously on how much you believe that the second-line ADT adds efficacy to the treatment of patients. So, and there is a big difference in Europe compared to US, right? In the US, patients usually get first line of ADT and then a second line of ADT. In Europe, people very often get one line of ADT and then switch to chemotherapy. But this again depends on the country, and I think overall the label will probably allow this. But please correct me if you think I did something wrong.
May I comment, Ken? Because, I think that is the question exactly to Mike, because in Europe, if we have the experience with the PSMA therapy, we have the castrate-resistant patient. That means that even with ADT, that we see the progression of the disease, and it is not so many dependent of this PSMA expression. We didn't treat the patient with hormone sensitive. But Mike, as I know, you have this experience with hormone sensitive, and do you have the experience that ADT in that kind of the patient have influence?
Well, so our patients sometimes are also having some of the urologists having the influence, and so most of them, yes, we have continued with them even if they were hormone sensitive. And then the urologist, in some instances, with the patient compliance, the patient didn't want to. But if you look at the work of, I think, the Australians, Emet, wherein he says hormone sensitive, hormone ADT can actually work the opposite versus hormone insensitive, castrate resistant. So then if you look at that work, that's a little bit tricky to actually combine them whilst they're still hormone sensitive. But clearly when they are castrate resistant, it would appear it's actually complementary. But that is preliminary work. And in fact, there's work that we must combine this effort to really settle this score once and for all. So at the moment, yes, it's not 100% dependent on us. Sometimes the urologist and the patient depend to be off because of the adverse effects and how they feel for their life.
In the US, it's pretty clear. Ken was correct. The patients are the vision population that we will be treating. They will be all post chemotherapy, and therefore then ADTs can be given or not be given up to the discretion of the treating urologist, of course. As it moves forward, there will be different indications that need to be approved based on phase 3 clinical trials here. So like the therapy trial will have to, the therapy trial will have to become a phase 3 trial. And then we will see whether the data hold up, which I would expect. And then of course, it's a different game.
You also see that the PSMA therapy goes to earlier lines. The PSMA addition trial, which I think is heavily recruiting, not yet in Germany, unfortunately, but I think US is already quite active, France is very active. And this is actually in patients with hormone-sensitive disease, and that's in combination with ADT. So I think we will get a lot of very, very exciting data.
There's also adjuvant treatments trials ongoing.
So then here's a comment which I want to read because I think it's very important. It's one of the beauties of this seminar because we really reach people also not only in Europe and the US, but really also in regions where maybe nuclear medicine is not as far established. And I want to read this from you. Sir, great presentation. I need your advice as I want to get trained in lutetium therapy and belong to a very developing country. What can be done in this regard? Can you recommend any help? And he also says, please do not forget about us. And I think it's a very important topic because we need to be aware that, yes, on one side we complain we don't have access yet to lutetium and maybe we don't have access to actinium, but the world is very heterogeneous. And I think this is also one of the roles of the World Federation of Nuclear Medicine to actually reach out And maybe this is a topic, I think, which is very timely. So who wants to comment on this?
I don't know, and I may say something, but the World Federation and the IAEA has got an important aspect. If the person is from a developing country and they may apply via the IAEA, for instance, to really say they want to go to UTLA, for instance, or they want to go to Poland, so they can choose a place. And if the hosting country agrees, then they can be placed there. And there are various situations. They can go for a scientific visit, for a 3 months fellowship, or for a longer term fellowship. Whilst the World Federation in this particular instance, and together with WOMF, World Association of Radiotherapy, can also help in especially developing countries to actually try and coordinate and help how to pair these people in the same similar situations as well, so that when they go back, sometimes they are in a similar situation wherein they can implement the situation.
And I think that Paola should comment, because she spent a lot of the time with the ESMIT, and the ESMIT is available for everyone because it is now this online format. Paola, please.
Thank you, Yola. Yeah, I would like to emphasize what Mike said, that the International Atomic Energy is supporting training. And as far as we decided to put a lot of investment in ESMIT online, you can reach out a lot of teaching sessions through ESMIT. And in Europe, for example, we are also having a lot of efforts in interdisciplinary training, because one of the questions that I like related to this is the fact that how you define the competence of a person trained in diagnostic. We have our resident training. Our residents are very well technically trained and they know how to perform things, but at that point they really need to go into the clinical arena and spend time with the urologists, with the oncologists, learning how they are treating patients to get the access of our treatment in the specific setting. So what we are doing, for example, is trying to establish a room or a specific path where this person can really go to the clinical department and spend time there, and through the multidisciplinary discussion, not only learn how to organize the service, but also when to use properly the treatment. And I think that this is the beauty of this webinar, that wherever we are working, everybody said that this is a top priority for the next years. And I would really like to have your opinion and a quick round on this topic.
Maybe to start this quick discussion round, I think, as Johannes already mentioned, there's going to be an initiative of a number of papers of the JNM, but not only of the JNM, also of the European Journal, really trying to actually reach everyone. For example, give starting advice how to set up a Theranostics center. There's a report from the Australian Society, how to train, how to educate. And Johannes, please comment on this, but I think this is just the beginning. There's many more coming in this direction.
Yeah, I mean, it's obviously, we are woefully inept in clinical competence as it pertains to being integrated in the oncology practice. We're not trained well. So I think part of it is more extensive rotations, clinical rotations that we need to do. And part of it is also setting the bar quite high in terms of qualification for who can run a diagnostic center. What kind of training do people need? How much clinical experience do they need to have? Are they really capable of serving as consultants? So I think the whole curriculum of nuclear medicine needs to change. So especially in the United States, Europe is far ahead of that anyway, but the United States has a fairly poor training, I would say, and the training is too short, and everybody can do nuclear medicine even if the training is only a few months. So that's not a good starting point for serving as a consultant for diagnostic services. So yeah, there's a lot of activities going to come from journals and professional organizations. There's a working group now in the US trying to set standards, and I wish they would include European experts and Asian experts and African experts, so that people with more experience could contribute to the curriculum.
Yes, we are in a little luckier situation in Europe because we are a little more trained clinically. It's a little longer residency. We have years in between the internal medicine and the oncology, but still it's very heterogeneous. Europe is a huge country, and we still have places where we don't even have a specific nuclear medicine training program. So still here there is a lot of work to do. But honestly, I also think that we need to cooperate, because I can't even think that the standard that is in Europe is not the same level of standard that will be in Africa, China, and US. So I think that the inter-society discussion of these minimum requirements would be very important, because patients need or must have the proper access to everywhere, independently of where they are living, and that is our responsibility to make it happen. Good. I think we are almost running out of time. It's already 2 o'clock, and I'm very happy to see how time flies when you are enjoying, as in this webinar. So I would like to conclude by asking you a very simple question. We are sometimes discussing about the same topic, but we are calling this differently. So for example, we don't even have a single definition of what we are doing. So if you have to make a choice among the many words you can call our treatment with radionuclide, because this is what we are doing, how would you like to call it? What would be? Is radiotheragnostic, theranostic, or radioligand therapy, PRRT? So it's so complex, so many acronyms that we can use. So I would like to start from China. What would be your first choice? How you usually call our practice?
Do you mean how we call this kind of therapy, like the radioligand therapy, like PRRT? I think we can simply call them the targeted radionuclide therapy. Like this is like more like straightforward.
Okay,
yeah,
but that is already a very good, clear opinion on that. So target radionuclide therapy. Mike?
Yeah.
Radiopharmaceutical theranostics. The reason being, of course, we've got to capture the radiopharmacy, because radionuclide might be slightly problematic because it might be an isotope only. And then theranostics embracing the fact that we see and we treat. We can't treat without see. So we've got to remind people that this is how we're going to go on with precision oncology, hence radiopharmaceutical theranostics.
Anna?
I use radionuclide therapy, especially. My experience is especially PRT, and I think that this short name is very good, and I don't know what.
But we are happy with that. I mean, it's something that we are also using many times. Radionuclide therapy is mainly one of the most used terminology. And in the States, what's the orientation? So what's the most common term you are using?
So we have molecular imaging, so I would call it molecular radiotherapy. And I think it also gives us some separation from the other fields that are encroaching on us a little bit sometimes.
But shouldn't it be then radionuclide therapy, not radiotherapy, to make sure we are different?
Molecular radionuclide therapy, we can do. That's a good one, Ken.
Okay, that's a good compromise. Yola, and I leave then the floors to you to conclude the webinar.
You know, that's Paula, you raised this the most important question in the end, of course, because you know that we are now using different words, and probably it's very difficult to say what it should be. For me, I like very much radiopharmaceuticals, because we are using radiopharmaceutical targeted therapy, because we target therapy. But you know, that's probably that will be not solved during this the meeting. I want to thank all of you for this meeting, and you see that we had today opportunity not once again talk about the theranostic only what is this, but a theranostic from the different point of view and for different part of even not Europe, but for the whole world. And on that way, I want to thank all our speakers for joining us, especially for Johannes. Once again, thanks a lot. You wake up very, very early because for you it was 4 o'clock. That's we need to thanks once again for you. With this, I want to conclude that hopefully we will see all together in Kyoto for the World Federation meeting, and then in October in Barcelona for EANM meeting. Thanks a lot for this meeting.